So as you see, we're going to be talking about prescribing cascades and a brief overview. The presentation isn't anything special. um, so fixing one problem with another, problematic prescribing cascades, and I'll outline to you why I've chosen 7 possible cascades to look out for. And as I said, the presentation will be posted, so you don't need to worry if you missed anything. Okay, so we're going to cover a few things. We're going to go over what are prescribing cascades, how are they traditionally defined. As you can see, going clockwise around the circle, we have 7 possible prescribing cascades that you might commonly see in BC prescribing. And then what we'll do is we'll identify some common themes amongst all the prescribing cascades and provide some suggestions for actions you can take. And I think the most complicated part of this for me is imagining as a clinician what it would be like for you to, one, identify cascades in your own set of patients that you look after, and 2, once you identify them, what do you do about it? So I'm not sure I have all the answers for that, but I have some suggestions that might make it a bit easier to try to optimize things once you identify. But not only about identifying prescribing cascades that are occurring, but trying to mitigate the risk of creating a prescribing cascade by catching them before you start. Anyways, we'll do our best to give you some practical tips to take away. Okay, so first, in terms of the definition, there are a number of them available online within articles or journal publications. I found one in Wikipedia, and what that one says is a prescribing cascade comes about when the side effects of drugs are misdiagnosed as symptoms of another problem, resulting in further prescriptions and further side effects and unanticipated drug interactions. So like the image on the first slide where the man is holding that ladder on a rickety set of stairs for a guy that's trying to patch up a hole in the wall above, the initial problem might, if you don't identify it in such a way, you could create another problem by trying to solve something and you don't connect the dots. So I see it as happening in settings where good people are trying to do the right thing for their patients, but inadvertently these things happen. And it may be because of maybe a lack of awareness about certain drugs causing specific adverse events, but maybe more so related to a gap in time, whereas you start a prescription, the patient starts using it, the adverse effect of that drug doesn't manifest immediately, and it manifests after a while. And by that time, that gap in time doesn't allow for a very seamless or quick thought process that links what you're seeing now to something that happened maybe months ago. And that comes up in the research around prescribing cascades. So regardless of why these things occur, I think it's useful to understand them. I just wanted to also let you know that we'll be publishing a therapeutics letter in the next 2 to 4 months, roughly, specifically on this topic, going into what I'll talk about in a little bit more detail. So stay tuned for that. So we're going to play a little bit of a game. My friend and colleague Tom Perry isn't here today. Otherwise, this would be more fun if I could actually poke fun of him when he was listening. But it's too bad. I will find another way to make fun of him when I see him next. So what I'm going to do is show you some scenarios, and you're going to try to think about what drug started that cascade, and then enter your thoughts in the chat. And I'll try to take a look. And what we did was we took the top 100 drugs that are prescribed in British Columbia in the last year. And from that list and a scoping search of the literature. So I basically went into the databases and looked for anything that talked about prescribing cascades, theoretically or potential prescribing cascades, and then went on to see if anyone had tested or evaluated to see if these cascades are actually happening in clinical practice in large geographic regions or in specific health regions. So that's how we came up with the 7. There's probably many more, but these appeared to be what we thought were the most common possible ones. So let's start off with the first one. I'm just wondering how I see the chat as well. Let's see. There we go. I'll open that for myself. Okay, so considering a diuretic for a patient that has symptoms of edema, and we already see someone putting in an answer in the chat, what could have caused the edema? So people are saying F, which is B, C, and D. And let's see what the correct answer is. And the correct answer is F, B, C, and D. And I'd have to admit that when I started thinking or was first introduced to the idea of prescribing cascades, gabapentin and pregabalin wouldn't have come to mind immediately. The one that I remember being talked about the most was amlodipine, or a calcium channel blocker, and you're all correct that amlodipine is part of it, but gabapentin and pregabalin are also implicated in leading to edema. And the numbers in parentheses that you'll note beside each drug is the ranking of that drug in terms of how common it is in terms of being prescribed in BC. So amlodipine is the number 8 most prescribed drug in BC, which to me is a surprise. Gabapentin, number 10, which is not a surprise, and pregabalin, number 81. I'm just going to share with you some of the evaluations that I found that support this idea that these cascades exist. I must admit, I haven't done a thorough critical appraisal of these evaluations. They were just interesting to me, that suggests that this may be something to look into further within our jurisdiction. This paper, entitled Evaluation of a Common Prescribing Cascade of Calcium Channel Blockers and Diuretics in Older Adults with Hypertension specifically, found that calcium channel blocker prescriptions led to greater use of diuretics when compared to other blood pressure drugs like ramipril or the angiotensin receptor blockers, with a hazard ratio of 1.64. And what they did was they looked between the incident prescription of calcium channel blockers, and then within a 90-day window was a diuretic prescribed. And it's a fairly large observation of 41,000 patients. So, and I know this one, as I mentioned before, this cascade has been talked about a lot in the literature. The next piece of information I wanted to share with you relates to gabapentin and pregabalin, and it's the evidence of a gabapentinoid and diuretic prescribing cascade among older adults with lower back pain. And in this one, gabapentinoid prescriptions led to diuretic use more than those without gabapentin, with a hazard ratio of 1.44. And again, they had a 90-day window. And with the cases and the controls, a population in this evaluation of around 260,000 people. And one interesting thing that gave me confidence that there's justification to be looking for this cascade is the likelihood of diuretic prescriptions increased the greater the dose of gabapentin was. And hang on to that thought about harm being dose related, because when I reflect on some possible solutions to prescribing cascades, this idea of dose response does come up. So we'll hold on to that. And again, as I mentioned in the beginning, why do prescribing cascades occur even though you have very smart, very well-meaning clinicians trying to help their patients? I think it may have to do with the gap in time, or the window after the starting drug is prescribed and when harm manifests. And because of that time, it's hard to, in a busy practice, to always make the connection between something that happened a while ago. It's just my guess. Okay, so the next one, considering oxybutynin for incontinence. And oxybutynin is the number 4 most prescribed drug in BC. What could have caused the incontinence? Would it be naproxen, simvastatin, donepezil, gabapentin, or all of the above? And I realized with my mechanism to poll you through the chat, it's thankfully there's no option F in this one, so I won't confuse your past answers with this answer. But if anyone's interested in putting something in the chat, what they think is the problem here. So Jane says C. Hi, Jane. It's nice to see you on the webinar. And Jane is correct that it's the cholinesterase inhibitor donepezil, which has been reported in the literature. And I'm not sure donepezil prescribing is very common, but at least oxybutynin would be. So at least you would suspect that some of the oxybutynin prescribing has to do with cholinesterase inhibitors. So when I looked for evidence to support this, that a prescribing cascade involving cholinesterase inhibitors and anticholinergic drugs was reported. And in this particular evaluation, they noted that cholinesterase inhibitor prescriptions led to bladder drug use more than those patients that didn't have a cholinesterase inhibitor, with a hazard ratio of 1.55. Now, they extended their window to 6 months, and they looked at a fairly large sample of 45,000 patients, again, suggesting that maybe part of the issue is the separation between the incident drug and when toxicity manifests. So something to keep in mind for the small number of patients that may be on a cholinesterase inhibitor. So there's a question in the chat: how do we know it's the drug and not the dementia? Well, it's a good question. It could be, and I think they try to, in these studies, control for this sort of confounding. Again, I'm no expert at appraising this type of study. I'm better at looking at randomized controlled trials, but based on my read, I think they try to adjust for other reasons that may increase the likelihood of being on a bladder drug. So that's the explanation they provided in the paper. So something to watch out for. Okay, so the next question: considering a proton pump inhibitor for heartburn, and just to note that in BC, ribeprazole is the number 27 drug in BC, esomeprazole number 66, and pantoprazole number 11. I suspect pantoprazole is higher than the other two because of the BC Pharmacare funding criteria. But if you're considering a proton pump inhibitor for someone that's experiencing dyspepsia or heartburn or some sort of irritation, dry cough potentially, which drug could have led to heartburn? So someone's responded E, all of the above, a lot of E's. And anyone that responded with E is correct. And it may be due to the anticholinergic effect that leads to decreased GI motility. And again, this has been reported. So in this particular case, one of our friends and colleagues from McMaster, Dr. D. Mangan, is a family practitioner who has looked at the issue of legacy prescribing. She didn't specifically, with her colleagues in this paper, look at prescribing cascades, but was interested in looking at so-called legacy prescriptions, drugs that are used well beyond the usual or approved indication duration. And in those particular patients, when they were looking at patients that had received a legacy prescription, PPIs were very common. And she noted that of the people on proton pump inhibitors, a large proportion, 17%, had a co-prescription with SSRIs. And they had looked at a big sample of 45,000 patients. So in her paper, her and her colleagues suggested that this may be a previously unrecognized prescribing cascade, which I thought was very interesting. And it did come up in my search because she she mentions the idea. Now, that is, I couldn't find any other studies specifically looking at PPIs and SSRIs. However, there is a study that I found that talked about anticholinergic burden, and that was a significant predictor of PPI use. So I think there's something to this, and it may be worth looking at ways in which we can investigate this maybe locally. But it supports the idea that a known adverse effect of anticholinergic drugs is dyspepsia. Antidepressants, many of them happen to be anticholinergic, and this signal that there may be something to why we're starting PPIs. It's because of their anticholinergic burden. If you're not familiar with the ACB score, if you Google ACB score, it's a website that allows you to type in the first few letters of a drug name, and it'll tell you whether that drug has anticholinergic properties. And then you can add all the drugs on the list that you suspect, and they'll show up or they won't. And it'll give you a score that's sort of a rough estimate of how much anticholinergic burden that patient is experiencing, and it'll give you an idea. That's one way to do this anticholinergic burden assessment. But nevertheless, if a patient reports with dyspepsia, you may want to look back and see, oh, I'll enter these drugs into ACB score and see if any one of them are anticholinergic, and it kind of, the timing makes sense. Something to consider. Okay, the next question, considering a laxative for constipation, what could have caused the constipation? So we've got verapamil, calcium supplements, candesartan, mirtazapine, or a combination of A, B, and D, or all of the above. Anyone willing to venture a guess? No takers this time? Okay, well, I'll tell you the answer, I think, is verapamil, calcium supplements, and mirtazapine. Mirtazapine happens to be the number 60 drug prescribed in BC. We have an interesting letter on mirtazapine that you can take a look at. But as it relates to this particular issue about what causes constipation, just some information that may support this idea. This evaluation looked at laxative agents in nursing homes, an example of a prescribing cascade, and it found that antidepressant prescriptions increase the likelihood of laxative use versus no antidepressant use. Again, in these studies, they tried to assess for confounding or other reasons to suggest these results and try to control for those. And what they identified was in the people taking antidepressants, the two antidepressants that stood out were mirtazapine and amitriptyline. Had the highest risk, and their sample size in this evaluation was 2,600 patients. Furthermore, another review looked at the use of laxatives among older nursing home residents in Finland, and they noted that laxative use was more likely with calcium channel blockers and calcium supplement users. So something to consider when you're looking at someone that's complaining of constipation and looking at their medication list for specifically mirtazapine because it's so common, and then asking questions about calcium supplements with their use of over-the-counter medications. And getting close to the end of our list. So considering a sleep drug for insomnia, zopiclone is the number 18 drug prescribed in BC. And what could have caused the insomnia? Methylphenidate, bupropion, venlafaxine, duloxetine, cyclobenzaprine, all of the above, or A, B, C, and D. And I see there's a question about the calcium and laxatives. I'll get to that in just a second. Any guesses for insomnia? So someone is saying G. A bunch of people are saying G. And the answer is G. Methylphenidate is the number 92 drug in BC, bupropion number 45, and venlafaxine number 43. And duloxetine doesn't appear in the top 100, but I think it's in the top 200. And so that's correct. As it relates to calcium increased bowel movements, calcium citrate, as far as I know, calcium induces constipation in some of the people that take it. I'm not sure about calcium citrate specifically. I'd have to check, but I'll try to get back to you about that. I couldn't find, as it relates to insomnia. Yeah, so there's another comment about magnesium citrate, and I know Citromag, the old stubby glass bottle that I used to dispense in community pharmacy is a laxative, and so maybe that's what you were thinking about, the person that asked the question. Okay, great. Oh, less. Okay, thanks, Judith. Less likely than other calcium supplements. Okay, great. Good communal effort to sort out that question. Thanks everyone for the help. I just wanted to point out that when I searched for drugs that can cause insomnia and prescribing cascades with C drugs or other drugs used for insomnia, I couldn't find anything. But as I said, I only did a scoping search. If anyone's aware of any literature to support this particular prescribing cascade, I'd appreciate it if you let me know. So feel free to email me. And moving on to the next one, treating movement disorders with a beta blocker or anti-Parkinson drug. What could cause a movement disorder? So we have quetiapine, sertraline, escitalopram, or all of the above. Someone saying just A, another A, another A. So I think it's D. Quetiapine is number 40, sertraline is number 42, escitalopram is number 15. I know it's a commonly used drug, but I was surprised that it's number 15. And I'll share with you some information that I found that may suggest that this is true. So in this case, this particular paper looked at neuroleptic drug exposure and treatment of Parkinsonism in the elderly. Neuroleptic prescriptions increase the likelihood of receiving an anti-Parkinson drug versus no neuroleptic use, an odds ratio of 2.2. And again, they looked at a 90-day window, and neuroleptic drugs would be drugs like quetiapine, increased incidence of levodopa therapy following metoclopramide use. Metoclopramide users more likely to receive levodopa versus no metoclopramide use. Odds ratio of 3. The likelihood increased with the dose, again, giving me more confidence in the association between metoclopramide use leading to toxicity and the need for levodopa, which is used for the movement disorder. And then one more paper looking at metoclopramide and levosulfuride use in subsequent levodopa prescription in a population of Korean elderly patients. Metoclopramide and levosulfuride users were more likely to receive levodopa prescriptions versus non-users. Both, for both drugs, odds ratios were around about 3 in a 90-day window, and 12,000, around 12,000 people examined in this particular evaluation. And so sertraline and escitalopram, I believe when we looked at the monographs, have some activity that would suggest that they behave like other neuroleptic drugs, and based on their toxicity profile, suggest that they also might be implicated in this particular prescribing cascade. Although what I've shown you here relates to metoclopramide primarily, is what you'd see in BC and quetiapine. And then this paper I didn't come across because I was doing some work around or thinking around prescribing cascades. But when I read it, I realized that it is kind of the same thing that they're getting at, and potentially a prescribing cascade. So this was published in 2021, and they looked at the prevalence of medications that may raise blood pressure among adults with hypertension in the United States. And they looked at the number of people that are on drugs that could raise their blood pressure. And here's what they found. Excuse me. They looked at thousands of patients. And there's a lot of numbers here, so I don't necessarily want you to focus on everything. But what I found interesting is the proportion of patients in the US population that are on one drug that may raise their blood pressure, and the proportion that are on at least two drugs that may raise their blood pressure, as well as the drugs that are most commonly the drugs that fall into those categories. So without worrying too much about the details in this table, let's look at the summary. What I read is about 1 in 8 patients will be on at least one medication that raises their blood pressure. About 1 in 40 patients may be on at least 2 meds that cause high blood pressure. And the use of these meds that increase someone's blood pressure increases the likelihood of antihypertensive medication use. And they try to control for confounding. So I guess what I'm thinking is it's not that uncommon for your patients to be on a med that might raise their blood pressure, that may not be recognized as an adverse effect of a drug and may be thought of as essential hypertension. And that may lead to antihypertensive medication use. Or in patients that have hypertension, their blood pressure may be higher because of those drugs that raise blood pressure that are used for other reasons. And so better control may be achieved by using less of the drugs that increase blood pressure, or rethinking the need for those. And you may be able to optimize the management in that way. So I thought it was an interesting example of a possible prescribing cascade that may need to be thought about. Anyways, it's a fascinating paper, and I was surprised by what they found in terms of the volume of people that are potentially impacted by something like this. So I took a step back and tried to think, okay, are there patterns here that I should be seeing? And I tried to, and there may be more patterns than this, but and you can tell me if you see any others, but what I see is that a lot of the drugs that I discussed today are anticholinergic drugs. So 15 of the top 100 drugs in BC have anticholinergic properties. Antidepressants came up a lot in the discussion today. So 10 of the top 100 drugs in BC are antidepressants, many of them which have anticholinergic properties. Antipsychotics may be an issue, only 1 in the top 100, but it is way up there. It's number 40. And when you look at drugs that raise blood pressure, specifically NSAIDs, 2 drugs in the top 100 in BC are NSAIDs, and steroids also potentially increase blood pressure, and 2 of the top 100 drugs in BC are steroids. So there's 5 classes of drugs that, if you had to focus on drugs that might be causing problems, it's a relatively short list. And given the number of times they're prescribed in BC, it's likely that 1 or 2 of your patients, or maybe more, might be someone that has this issue, a prescribing cascade. So something to consider. At least helps you, instead of worrying about everything. I'm hoping this short list will give you a small number of items to start thinking about. And I playfully suggest that you use some of the tools you have at hand and try to boil it down to some simple tasks that you could accomplish relatively soon or iteratively. I don't have a clinical practice anymore, so I don't understand all the issues that you deal with in clinical practice, but I'm hoping this helps. If you have other suggestions, please put them in the evaluation form, because I'd love to be able to share them with others if you can pass them on to me. So first, common things happen commonly. So look back and see if any of your patients are on anticholinergics or have a high anticholinergic burden, or on antidepressants or on antipsychotics. And if those patients could be flagged somehow, or if you have those in your mind, and the next time you see them and do a medication review, or they're in front of you and you're trying to help them deal with a new medical problem, and you notice that they happen to be on one of these classes of drugs, try to ask yourself, could what I'm having to deal with today with this patient have anything to do with these drugs? And because they're so common, I think maybe sometimes it'll lead to a red flag. Let's see, I've got a question here. Do SSRIs only cause movement disorder symptoms in the context of mild serotonin syndrome? I don't know. I wish Tom was here. He may be able to help me with that question. I will look into that and get back to you. I don't know if the person that responded above you has some information, but anyways, I'll try to get back to you with an answer. I apologize for not knowing. The other main point, I think, would be don't fix one problem and create another. If you see a possible prescribing cascade, one thing to do would be to consider, for the drug that might be starting this problem, to reduce the dose or reassess the need for the drug. Now, I know some of these drugs, especially some of the anticholinergic or antidepressants or neuroleptics, you can't necessarily stop them cold turkey unless there's an immediate concern for the patient. But dose reduction is a possibility to see, because a lot of generally speaking, when we look at efficacy and safety evidence for drugs, many of the times, the dose response claims for efficacy don't pan out when you look at the evidence. But dose response mostly seems to be associated with harm. So the higher the dose, the more harm. So lowering the dose may reduce the harm and prevent the need for the drug that you may have prescribed as part of the second step in a prescribing cascade. So it's one possibility, is to consider reassessing the need, and if not, reducing the dose or tapering. Oh, and if you pay attention to the last comment in the chat, Dr. Farrell, and thanks, Barb, for putting this in. There are some qualitative data from interviews with patients and healthcare providers about prescribing cascades that might be informative as well. So there's a link in the chat for that. That's great. Thank you for sharing that. Okay, and I don't know, like, this is something I'm interested in testing, but there's some literature around sequence symmetry analysis for identifying possible prescribing cascades. And it's I think that's my understanding, that's a fancy way of utilizing databases to determine if Aaron is on drug A and also on drug B, and then to further analyze whether drug B came soon after the prescription for drug A, and then identifying patients in the population that had not only those two drugs, but the timing was right. So a lot of the prescribing cascades that are theoretical have panned out when sequence symmetry analyses have been done. There's an interesting systematic review of all those studies. If you're interested in looking at that, I can send it to you. Just send me a note by email. But it makes me wonder, could we harness the technology or the capability of an electronic medical record that's used in primary care to identify patients or red flag those that might be possible prescribing cascades? So if you could put a tag on every patient that is on one of the 7 drugs that are implicated here, as a way to alert you the next time you see them, oh, check for a prescribing cascade. Or if with the help of a network of primary care providers that have EMRs, if we could mine all of them to identify how common these problems are in BC. Anyways, I think for clinical practice, one thing to do would be to have a set period of time where you try to make an effort to focus on any one of the 7 I mentioned today to see, in the next week or the next month, every time you see a patient, to think about, are they on an anticholinergic? Are they potentially also getting a treatment for something that may be anticholinergic toxicity, something like that? So just as a way to get started and build momentum. And then the next month, it might be picking the second of the 7 in the list today and getting started. Within the therapeutics initiative, we're talking about trying to do some assessments or evaluations in BC. We haven't quite figured it out yet, but it's possible that we will. But at the very least, if you do try some of this in your practice and have some good, bad, or other experiences, we'd love to hear about it. So if you have the time to let us know how it's going or what you did, I'd be interested to learn about that. That is all I had to share today. Oh, I see another contribution. I don't know about SSRIs and SNRIs having a separate mechanism for movement disorder, but commonly see tremor with higher doses and in combination with other drugs that have serotonergic effects and diarrhea too. Thanks, Barb, for adding that. And that relates to a question we had earlier. So we're a little bit early, which is great. If you have any further questions or comments, please put them in the chat. Before I get to those, I just wanted to say thank you so much for taking the time out of your day to spend with me and the Therapeutics Initiative. Don't hesitate to put in any constructive criticism in the evaluation form, even if you're not interested in continuing education credits. We're happy to get that feedback, and we try to improve as much as possible. Keep a lookout for the Prescribing Cascades letter, which will be coming soon. And we hope that we'll have you subscribe or see you at one of our upcoming events in the near future. So I'll give it a couple of minutes and see if anyone has any comments or questions. If you want to sign up, feel free to do that. But thanks again, everyone.